Hi, everybody. My name is Katie Golden. I'm going to give just maybe another minute or two for people to join. But thank you all so much for taking time out of your day, to join us for this really, really important discussion. So just kind of getting the heads up from everybody that it's working on all ends, and it seems to be so. So let's begin. All right. Again, my name is Katie Golden. I'm the Migraine Advocacy Liaison for the U.S. Pain Foundation and contributing editor for the Invisible Project Headache and Migraine Editions. Thank you again for joining us this evening for this really important discussion on healthcare disparities in migraine and headache care. We have a really diverse panel tonight. So you will, Nim Lalvani, Isiah and Sheila Lineberry, LaQuinda Mccoy, and our moderator, Jaime Sanders, will be joining in just a minute. All of the participants tonight have been featured in the Invisible Project magazine. The 4th edition just came out earlier this month, because June is National Migraine and Headache Awareness Month. So tonight, our panelists will briefly share how discrimination and implicit bias has negatively impacted their access to appropriate medical treatment. So before we begin, just a few housekeeping items. We are recording this event, and it will be available for you to watch and share later through via U.S. Pain Foundation's social media channels. And you can ask questions, whether you're joining us from Zoom, put them in the chat, or if you're on Facebook and you have questions, put them in the comment section, and we will have at least 10 minutes at the end for question and answer period. And we really encourage you to join us in this dialogue with open minds so that we all can work together to create change. And thank you to our generous sponsors. Without their support, this event would not be possible. So thank you very, very much. And lastly, consult your own healthcare professional with questions about your specific medical issues, as the panel is not providing or able to provide medical advice. And we'll also be putting some links into the chat and Facebook comments as the discussions happen. There are quite a lot of resources that we're gathering, and hopefully tomorrow will be available on U.S. Pain Foundation, and we'll put those out through our social channels as well. So let's begin. I want to introduce, and then I'm going to get it out of the way, our moderator for this panel I'm very honored to say that she is one of my closest and dearest friends, Jaime Sanders. Many of you know her as the Migraine Diva. She is the author of the blog and website, the Migraine Diva. She is a stakeholder with CHAMP, the Coalition for Headache and Migraine Patients, and the Headache and Migraine Policy Forum. She has served as the Migraine Patient Advocacy Coordinator for the Global Healthy Living Foundation and continues to partner with the American Migraine Foundation and Shapes for Migraine. She advocates for migraine awareness through her writing, speaking, and by participating in events such as Headache on the Hill. And I am going to try to figure out slides, but Jaime, take it away.
Thank you so much, Katie. And thank you to the U.S. Pain Foundation for putting this together. This is such an important topic, and I'm very honored to be able to moderate this wonderful panel of guests. And I just want to welcome our wonderful panel. We have Nim, Isiah, Sheila, and LaQuinda, so welcome everyone. And I'm just going to introduce everyone, give you a brief background of who we have tonight. Nim Lalvani is the Executive Director of the American Migraine Foundation. Nim has dedicated her career to the furtherance and understanding of patient engagement, patient programming, and patient advocacy. Nim has held patient-focused and leadership positions at organizations including the American Migraine Foundation, the National Kidney Foundation, Young Survival Coalition, the New York State Health Foundation, and the New York Academy of Medicine, among others. Nim's diverse experience in patient advocacy and nonprofit management enables her to understand the desire of patients as it relates to education, support, advocacy, and how organizations can better meet the needs of their community. And we have Isiah Lineberry. Isiah has engaged in efforts for over 20 years to improve the health and well-being of individuals and communities, particularly in rural areas. Currently, Isiah serves as Senior Program Director for the Gulf States Health Policy Center. He is responsible for managing a $13 million National Institutes of Health, National Institute of Minority Health and Health Disparities Research Grant. Isiah is a loving caregiver for Sheila, his wife of 36 years, who endures chronic migraine. He is the father of 2 adult children who also live with chronic migraine, from whom he was their caregiver when they were younger. And we have Sheila Jones Lineberry. She is retired from the South Carolina school system and has had migraine for over 30 years. Sheila has worked for 4 major Great Society programs passed by the U.S. Congress to eradicate disparities: Upward Bound, Job Corps, Opportunities Industrialization Council, and the Job Training Partnership Act program. She possesses a bachelor's in sociology, and her master's in community health education is from West Virginia University School of Medicine. Sheila has been married to Isiah for 36 years and is the mother of 2 daughters, attorney Mercy Lineberry McDaniel and Litany Lineberry, who is Mississippi State University PhD engineering education candidate. The Lineberry family was also featured in the award-winning documentary Out of My Head. And we have LaQuinda Mccoy. LaQuinda worked as a liver transplant nurse for 12 years. She is an ambassador for U.S. Pain Foundation and is California's state representative for Worldwide Endometriosis March Advocacy Day. In 2019, she began sharing her story with local businesses in an effort to help improve workplace accommodations for those living with migraine. She is featured in the Invisible Project Migraine and Headache 4th edition and is in the 2nd edition of My Chronic Brain magazine. And she recently wrote for Champ and started writing for Migraine Again. LaQuinda's mission is to empower and educate. She wholeheartedly believes the smallness in giving someone information about your journey is compelling. You can find her on Instagram and Twitter at Advocacy with Q. So welcome everyone. Thank you for joining us tonight. Well, first I want to kick everything off with this first question. And I'd like to ask each of our panelists to briefly tell us about their background and heritage and their migraine and headache journey. Nim, could you start us off?
Thank you, Jamie, and hi to my esteemed panelists. Well, my background is pretty interesting. I'm first-generation American, born and raised in New York. However, I identify as Indo-Caribbean, and what that means is my grandparents and great-grandparents were born in India, but they were taken to the Caribbean as indentured servants. And so my mom was born in Jamaica in the West Indies, and my father was born in Guyana, South America. So I have many layers of cultures to play with and enjoy, which I'm very proud of. Additionally, I'm a migraine patient. I was diagnosed at around 19 years old when I was at university in Boston, and I have hemiplegic migraine. And so it was a very interesting journey to have been diagnosed when I was that young, and also when I was living away from home for the very first time. I was about 5 hours away from my parents, and every time I had an excruciating attack, I would call them, I would be in the emergency room, and they would have to drive up. And so they're my hugest supporters, and I'd like to take this opportunity to thank them for being that support system for me. Thank you.
Thank you so much, Nim. Isiah and Sheila. You're on mute. You have to unmute.
Okay, can you hear me now?
Yes, we can.
Okay, thank you. I was raised in Charleston, West Virginia, went to school there, graduated from the University of Charleston, and I do not have migraines. I am a caregiver. And so my journey with migraines began when I met my then fiance in Augusta, Georgia. She was having serious brain surgery at the time. She would complain about headaches before we got married that I had no idea what that meant. I just thought it was a headache. Then once we were married, I became the caregiver. And so I had the opportunity to see the debilitating impact of her migraine, chronic migraines. It was, for me, a sense of helplessness. She couldn't stand the light. I had to whisper. Sometimes I couldn't talk at all. She couldn't keep food on her stomach. She was not able to function. She would just lay in the bed quietly. No medication would relieve the pain. I would have to take her to ER. 3 days later, she might be better, but often there was a rebound. And at that time, she was still severely weak from the experience. And so being a caregiver was really, really challenging because I didn't know what to do. But through the process of, over time, and her able to get some treatments that were able to mitigate the pain, that helped. And then the connection with National Headache Foundation. Bob Dalton was the executive director then. Just by chance, we went to an outreach meeting that he had, and he wanted us to be involved in outreach, particularly to minority communities. That led to Headache on the Hill participation, then to the recruiting for the film, Out of My Head, and then the wonderful participation with U.S. Pain Foundation as ambassadors. And so that's been my journey, but it's been a journey with my wife, who will tell you about her experiences.
Hello, everyone. My name is Isiah Lineberry, and I was raised in Augusta, Georgia. I'm an only child, and I'm a child of the first African-American nurse there at Medical College of Georgia. And my dad was one of the first African-American police officers hired there in Augusta. So I was privileged to go to private school for 12 years. I went to college, and of course I obtained a graduate degree. When I first started having what I thought was headaches, I was in college, and everybody was saying, oh, you're having headaches, you're having headaches. But whenever I discussed it with my mother was like, no, it sounds more serious. It sounds more like you're having migraines. So through my mother, it's a long, long story, too long to tell you guys. I was taken and I received care there in Augusta because of who she was, because one of the first floors that she'd ever worked on as a nurse was a neurology floor. So she could relate, and of course she had migraines herself. So my care, as long as I was in Augusta, because of who my mom was, who my dad was, I was like this little shining star, so I was good. And it was not until I transitioned from Augusta into a new environment, into West Virginia, and it's like, who is this person that's coming in with pain? who is this person that is complaining all of the time that this person is sick? And my journey starts from there. The challenges starts in West Virginia, and I'll talk a little bit more about that later.
All right, thank you, Sheila. Thank you, Isiah. LaQuinda, please tell us a bit about your background and your migraine journey. You're on mute, LaQuinda.
I'm sorry. Hi, everyone. My name's LaQuinda, and I am originally from Shreveport, Louisiana. I moved out here to Los Angeles, California in 2003. And I have been suffering from migraines since I was maybe 12 or 13. You know, at the time, I didn't know they were migraines. I just, you know, thought they were bad headaches. And, you know, I would reach for over-the-counter medications, Excedrin, BC powder, you know, anything that I could find to, you know, help relieve that head pain. And I've been in this kind of tug of war between episodic, being episodic and having chronic migraine. But I was officially diagnosed in my early 20s. And, you know, that's when I was actually able to get on, try some preventative therapies that didn't really work out too much for me. And I, you know, to be frank, I really wasn't going to the doctor's, well, my physician's primary physician office as often as I should. I would find myself more so going to the emergency room because at that time I couldn't wait for an appointment to, you know, to the primary doctor. I needed relief now, and so I was, you know, seen as this frequent flyer. Oh, she's just here for, you know, narcotics, and I didn't want narcotics. I just wanted pain relief, and so like I said, off and on through episodic and chronic, and I actually graduated from nursing school. I was have been working as a liver transplant nurse for the last 12 years up into 2018, where my migraines took a huge shift and became every day. I was having migraines every day, and my preventative medication wasn't working. My rescue medication wasn't working. And I just remember feeling hopeless, like I need help right now. I just remember calling my primary doctor's office saying, hey, I need to see a specialist. Like, I need help today, not tomorrow, not next week. And I was able to actually get referred out to a headache specialist that was able to get me started on my journey of getting better treatment. And so, like I said, I wasn't able to work due to the migraines. So I have been off work for about 2 years due to my chronic daily migraines. And I went to my first migraine retreat last year. It was the first one that they had. And I just really went there because I wanted to learn more about my, you know, disease. I wanted to learn more about migraines. I wanted to be around people that understood what I was going through. And I'm so glad that I made that choice to go because I learned so much. These amazing organizations like Migraine Foundation that do so much work getting us the information and the education we need. So that's pretty much my journey with migraine.
Thank you so much for sharing, LaQuinda. And I know personally the struggle of having chronic daily intractable migraine. It's tough. And it's really difficult getting through each day, trying to find a purpose every day. So I champion you and I honor you just for being here today.
Absolutely.
So we're going to go over some terms that we'll be using today. I just want to make sure everybody has some type of context about what we're talking about. when I'm talking about disparity and implicit or unconscious bias. So we're going to go over a few slides really quickly. Healthcare disparities are rooted in the following: race and ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. Next slide. Disparities in underserved populations with migraine or headache diseases. Compared to their white counterparts, Black headache patients are more likely to be diagnosed with comorbid depressive disorders, register more frequent and severe headaches, have underdiagnosed and or undertreated headaches, discontinue care early regardless of their socioeconomic class, can lead to disease progression, and it disproportionately affects their quality of life. Next slide. In a 2014 National Health Interview survey, which tracked the prevalence of migraine among different races, it does show this is with migraine epidemiology and burden and comorbidity of migraine, that 19.20% of American Indians and Alaska Natives have higher prevalence of migraine, compared to 15.5% of whites, 15% of Black and African Americans, 14.9% of Hispanic and Latinos, 13.2% of Native Hawaiian or Pacific Islanders, 10.1% of Asians, and 12.1% of who categorized as other. And it's important to note that epidemiologists' best estimates suggest rates of migraine vary across demographic groups. However, it's not clear why these rates vary. The physical expression of migraine can look really different in different populations, and these populations may differ in their willingness to talk to survey researchers. So we need to look at these numbers subjectively, just because the way different groups of people may present their symptoms and how comfortable they may feel in speaking about their symptoms to researchers or clinical researchers may not actually be the same as, say, our white counterparts. Okay, next slide. Now, when we speak about bias, bias is an algorithm of the mind. Implicit or unconscious bias is ingrained habits of thought that leads to errors in how we perceive, reason, remember, and make decisions. Consequences of this bias are bias, stereotyping, prejudice, and clinical uncertainty on the part of healthcare providers may contribute to racial and ethnic disparities in healthcare. Okay, this topic is very important to me because I have experienced instances of bias throughout my patient journey. And I've had a very long history with migraine. It started when I was 2 with abdominal migraine. I was officially diagnosed at the age of 8, but I had a very unique upbringing in the healthcare system. My father was one of the original people that started this healthcare center in the Southwest Bronx called Morris Heights Health Center. And the purpose of this center was to create a community health center that served the indigent people of the Bronx. And these were primarily Black, Hispanic, and Latino people. And this is during the early 80s. And at that time, there were things called Medicaid meals. Most of these people were on government insurance. They had Medicare or Medicaid. However, the only way they can receive services was by going to the hospital. There were no specialty care services for them in their communities. So with the birth of this healthcare center, they were able to address the needs of that community and reduce the disease burden of those living in that community. HIV and AIDS, obesity, asthma, hypertension, infant mortality. My father brought me and my sisters to this healthcare center for our treatments, to see our pediatricians, to get our dental care. So I grew up seeing doctors that looked like me and talked like me, and I felt comfortable. However, when I became 18 and left the house and became an adult and was thrust into the reality of the healthcare system, it was a completely different experience. And as my migraine progressed and got worse and more frequent and less responsive to medication, the more I found myself having to really use my voice to be validated and be heard, because I was being more dismissed. And that was just such a contrast to what I was used to as a child. So it is my hope through conversations like this one that we are having tonight, and through actionable items from headache and migraine organizations, to be more aware of representation of their leadership, communities, and services, that we can narrow the gap on racial disparities. So I want to ask a question to our panelists, and I'll start off with Nim. Do you remember the first time you realized you were being treated differently by a healthcare professional?
It's a really good question, Jamie, and an important question, because, you know, in preparation for tonight's discussion, and when I saw that question, it really made me think, because I think I've been so used to what the system felt like that I never processed it as being treated differently, especially in my earlier years when I was trying to get care, and especially for pain. And when I think back to those earlier experiences of going to the emergency room when I was having those cycles of pain with migraine and my other conditions, I remember distinctly, you know, being questioned, and the way I was being questioned felt so uncomfortable, as if what I was saying wasn't right, or maybe I was saying it in a way that didn't make sense. And so the doctor would ask me, "Are you sure that's what you're feeling?" So I felt dismissed, because I'm clearly saying what I'm feeling in my head or in my back or wherever the pain was. And, you know, he still asked me if I'm sure. Then the follow-up question would be, is there something going on at home? Maybe you're stressed. Maybe it's something else happening in your life that you're not feeling well. And no matter how much I pleaded and saying, this isn't about my home life, this isn't about what's going on outside here, it's about my head, it's about this pain, and I really just need help, or I need answers, and I need someone to help me. And that became very frequent. And the added layer of that, you know, the feeling of dismissal, constantly being questioned and scrutinized, was also my age. I was young and I was trying to be heard, and, you know, oh, you're too young to be in pain, or something else is going on, or feeling like no matter how much I tried to explain myself, nobody was taking me serious enough. And as the years progressed, my oldest brother became a healthcare provider. And when I moved back to New York from Boston, I started going to his hospital for my care. And so I relate to your story. When someone looks like you sort of go into this bubble of safety. And up until that point, I never had providers around me that necessarily spoke my parents' dialect of being Caribbean and Indian or whatever, all of the other things. And when my brother stepped into that white coat, people started to pay attention to me more. He would go and make sure, you know, that's my sister, she's in pain or whatever. And so it's really interesting to me that no matter how much I tried to explain what was going on, and how many times I felt dismissed, and using my voice and step into my comfort zone of saying, listen, this is pain, you can't dismiss me, it still took someone else to do that for me. And that was really disappointing, even though I was grateful to have that connection.
Yeah, I can completely relate. My father's Jamaican, and a lot of my family on my mother's side's Jamaican, and a lot of the people that started this health center were from the Caribbean as well. So there's a lot of that you know, that familiarity.
Mhm.
So I understand when you're in that, you know, that community of people, it's like, oh, okay, you do have that safety feeling around you. So I do understand that.
Absolutely.
Yeah. So thank you for sharing that. LaQuinda, could you please share if you remember the first time you realized you were being treated differently by a healthcare professional? You're on mute.
Sorry. Yeah, that is a good question. And I was sitting here thinking about, you know, there's been several moments where, you know, I've been treated differently, but the one that really stands out to me, I was in a, you know, in an appointment with my GYN doctor. And I remember I needed to have a biopsy done. And he was just very cold to me. And I remember, you know, asking, hey, do I need any, anesthesia, any type of local anesthetic? And he was like, oh, no, you know, you don't need that. And proceeded with the procedure. And I just remember being in so much pain. And I literally could not walk. I could not walk out of that office. I was in so much pain. And he was like, well, you know, you really shouldn't be in that much pain. You know, I don't understand, you know, why you're saying you're in so much pain. You know, this isn't a painful procedure. And I'm like, whether you think it's a painful procedure or not, I'm in pain. You know what I mean? I am cramping. I can barely walk. It's sharp stabbing pain. I need something to go home with. And he's like, no, you know, just take some ibuprofen. And I'm like, ibuprofen isn't going to help with what I'm feeling right now. You know what I mean? And he's like, well, now we're talking about narcotics and, you know, that's, you know, can lead to, you know, abuse. And I'm like, but I'm not a drug addict. So, you know, I don't understand how this is stopping you from giving me pain medication, even if it's for 3 days, to, you know, help me with my pain while I heal at home. And, you know, I left out of that office and I was in tears. I left out of that office hopeless. I don't think I've ever felt that low at a doctor's office before. Everything that I said was dismissed. And I remembered, I was just thinking, you know what, I can't let this doctor get away with this. I immediately wrote a grievance. I, you know, spoke with the office manager. And then I actually changed, you know, positions. And, you know, that was a big step for me, speaking up for myself and, you know, holding that practitioner accountable for how he treated me, because it was so bad. So yeah, that's one of the ones that really stood out to me. Definitely of not being heard.
I'm so sorry you had to experience that, LaQuinda. And unfortunately, that's not uncommon when it comes to disparities and just analgesic treatment for pain. African Americans are 22% less likely to receive any analgesic for pain conditions such as backache, abdominal pain, and migraine. So this is something that happens a lot of times even after major surgeries, with cancer. This is a huge issue. And unfortunately, your story isn't unique to you, and it shouldn't ever happen to anyone. And I'm so sorry you experienced that. And but I thank you for sharing that.
Thank you.
Isiah and Sheila, if you could share an experience that you have gone through where you felt treated differently.
Sheila, go ahead.
Whenever I moved out of the comfort zone of being in Georgia, where I had my mother as an advocate because of who she was, moving to all the way up to West Virginia, which doesn't seem far because it's below the Mason-Dixon line also. And whenever I would be in a lot of pain and I would make an appointment to see my physician, I would always be not taken seriously. And because of the frequencies of my headaches, I was always asking to be seen. So one of the initial diagnosis that the doctor said, he said I was suffering from anxiety. Now I'm having a migraine, but it's anxiety. So I was prescribed Valium. And I was like, but I'm having these headaches. I wasn't couching them in terms of migraines, but I was saying I'm having these severe headaches. And so we progressed from Valiums to Prozac, until finally I kept saying I'm having these headaches. And what made the difference is, and I really hate to say this because I'm a very independent thinker and I'm a very independent woman, is when I started to take my husband to the doctor with me. Now I have this person that can validate me, which I should be able to validate my pain and myself, saying, no, my wife is suffering from these migraines. She's, you know, she's throwing up, she can't stand light, she's having this symptom and she's having that symptom, until that's when I was taken serious. Whenever my husband started to accompany me to the doctor's visits.
And a part of that is my career, in addition to where I am now, has been in healthcare. I was director of rural health for West Virginia. I was executive director of Georgia's Office of Rural Health Services. And then I was also deputy director for Robert Johnson Foundation National Program. And so I was able to bring some of that experience being in the healthcare field to the setting with my wife, to be able to ask questions that would kind of give the clinician some indication, oh, this person knows what he's talking about. That should not have been necessary, but nevertheless it was. My own experience, I don't have migraines, but I have an adverse experience at the Academic Medical Center in South Carolina, where I went to ER. I had a complaint regarding back, and then my back pain. Then I overheard the clinician, he was white, saying to someone else, "Look, I don't think it's as serious as he says, and that's what I'm going to put in the chart." I challenged that, and also made a complaint. I was totally unprofessional. And then in Alabama, I've had several excellent Caucasian physicians who are patient-centered, patient-focused. But I've also had several very adverse experiences with physicians who were intimidated by my intelligence, by my Blackness, by my ability to make intelligent inquiry, and who were very dismissive. And one person said, well, look, if you're going to be going to the internet, you just don't need to waste your time with me. And then another situation occurred when I came through a procedure for PAD, peripheral artery disease. I was still kind of out of it, but because when the physician came to the room, rather than talking to my wife about what was going on with me, he threw the chart at her. So
honestly, he did.
But I do want to emphasize I've had positive experience with white physicians, but I've had some very, very severe adverse experiences as well.
Thank you for sharing. One thing I also want to point out is that these experiences can happen among and within other groups of people of color. And I have experienced that personally with a Hispanic doctor in the urgent care setting. And there is historically, with some Hispanics, an issue with Black people. And this particular doctor referred to me as an object and not a person, and constantly questioned whether or not I was doing enough to take care of my migraine. And it wasn't until I went down a laundry list of everything I've done over the past 10 years and what my insurance has denied me from trying to do that I want to do to get better, did she go ahead and follow my protocol? And I should not have had to do that. But this is to say that this isn't strictly between people of color and white people. This is broader. So we do have to delve between whatever biases exist between other groups of people of color simply from the fact of colonialism. So that's another point I wanted to make, and just expand and enlighten people of, just to, you know, research and look a little further into. I'm going to move forward because we're kind of running out of time, and I want to make sure we get to people's questions at the end of the hour. So if we can get to the slide on doctor and patient relationships, I greatly appreciate that, because that's a very important piece, especially historically, when it comes to the mistrust between particularly African Americans and medical professionals. But subtle biases can be conveyed that can affect patient-physician contact. And ways this can happen are by approaching patients with a dominant and patronizing tone that reduces the likelihood that patients will feel heard and valued by the providers when needed. And we had examples of that by our panelists just now. Doing more or less through diagnostic work, recommending different treatment options for patients on the basis of assumptions about their ability to adhere to treatment. And this is something that occurs way too often among people of color when in contact with physicians. So I like to go back to the panel and pose this question and ask about your personal experiences with physicians where you were not treated fairly or your voice wasn't valued or heard. And Isiah, you mentioned that living in Mobile, Alabama, it was a bit different for you. What was your patient-physician contact experience like outside of the examples that you just previously showed us?
Other than the examples that I referenced, it was excellent. Excellent patient care, excellent diagnostic, and particularly one clinician would draw blood on a regular basis to track some of the things that I was dealing with. There was never an imposition in terms of asking questions about, you know, the impact of a particular treatment, or to raise a question about the results of different tests and things. So, so in terms of the affirmative, yes, and I've already articulated, you know, the challenges that that I face with some physicians. That's quite unfortunate. I was in a position though to have an option because I've worked in the healthcare system. And so I was able to navigate getting to another clinician that was patient-centered. Not everyone has that flexibility. Not everyone is comfortable making that transition. They may not know who to ask for. You know, who can I see, because this doctor's not really working with me. And so one of the things we need to do is to find some ways to help patients who feel they need to transition to find physicians that are patient-centered.
Absolutely. And Sheila, if you could expand a little bit more on your experience in Charleston, how did that make you feel when they were dismissing your headache and migraine symptoms and basically boiling it down to a mental health issue and just prescribing the Valium and the Prozac? How did that make you feel?
In one word, angry.
Understandable. Unfortunately, there's such a history of, especially Black women, their pain being dismissed. It's almost as if we're seen as inanimate objects that aren't able to feel pain. And sometimes we are treated as such. And it kind of projects itself when we are in that doctor's office, depending on that physician that we're in contact with. And this is, you know, a reality for so many of us. And it's important that we bring that to light and share those stories so that other people can understand these are these invisible barriers that we have to deal with when we go to our appointments that so many people don't have to think about, but we are constantly observant of, cognizant of, aware of, and understand that there's a huge possibility that this person is just looking at the color of my skin and is going to treat me based off of that and not as a human being with valid issues.
Jamie, one of the points on the last slide around patient adherence based on, you know, your race, it's really important to note that, you know, doctors have an equal role to play whether a patient adheres to their treatment plan or not. You know, I've definitely been one to not adhere to every single treatment plan that was prescribed to me because I felt that that doctor wasn't hearing me, or that last experience I had in the office just turned me off completely from wanting to continue down that pathway. And so it really does go back to how we are made to feel when we're sitting in that office will dictate what happens when we go back home. And us not being able to adhere to a treatment plan isn't entirely our problem or our failure. It's the failure of the provider to make this a comfortable journey and making it patient-centric. And I think that's really key in understanding how this narrative has to turn.
Yes, exactly. Thank you for pointing that out and sharing that and expanding on that, because that is very true. LaQuinda, your experience in applying for Social Security disability and dealing with the inaccuracy of your medical records, could you walk us through that and how it took you disclosing your occupation as a nurse and that changing the dialogue and actually getting some actual actionable things happening in order to get progress? Explain how that experience was for you.
Sure. So, you know, I started the process when I first went off on disability in 2018. And I just remember, you know, getting a lot of pushback from the insurance company and them not, you know, wanting to approve it. And I really couldn't understand why this was. You know, I have the documentation of failed treatments. I mean, many failed treatments. I've been suffering with this disease since I was an adolescent. I've been in and out of hospital. I have all this documentation readily available, and yet I'm being denied. So I really couldn't understand it. Another thing that what was happening is that I would be in the doctor's, I'll be, you know, speaking with the physician regarding what my migraine feels like, how many I'm getting a week, how long does it last, what are my symptoms. I'm completely, you know, down for a day. You know, it's not just the head pain. I'm having dizziness, nausea. I can barely see. You know, I'm explaining to him all these things, but what I found was that he was not putting any of these things in my chart. None of it. And what me being denied actually prompted me to say, hey, you know what? Let me go get my notes. Let me get all of my notes so I could see exactly what this physician is writing in the progress notes. And when I found that out, I was really baffled, you know, because this person is staring me in my face. He's sympathizing with me. Oh, I totally understand. You know, yeah, that sounds really, you know, yeah, there's no way you can work with those types of symptoms. But you're saying something completely different in my chart. Oh, the patient, you know, she's able to work through her migraines. She only gets 13, which that's not what I said. You know, I'm getting 20 migraines or more a month. So, you know, and then when he found out, because I started actually, you know, speaking a little bit different. I started to change my tone of how I was speaking. And he was like, "Are you in the medical field?" And I was like, "Yes, you know, I'm actually a transplant nurse." And things just changed. Things just changed. And his tone changed. I noticed that the documentation started to get better, you know, and I just couldn't understand, why weren't you doing that before? Why did it take you finding out that I'm, you know, a healthcare professional like you, for the tone to be changed, for you to start doing what you should have been doing in the first place? So I just, you know, that's one thing that I'm like really vocal about now when I speak to people, is to make sure that you get your medical records. Each time you leave the doctor's office, request your progress notes and make sure that whatever you're saying in that visit is being accurately documented. If it's not, email your physician. Point it out. Hey, you know, you didn't, this isn't accurate. I actually stated that, you know, blah, 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 and get them to redact that. You get what I'm saying? So that when you, if you ever need to go on disability or need that paperwork for something else, you have the accurate information and you can get the treatment or the things that you need, you know. So I just highly recommend, you know, you all, you know, get your records after each visit.
That's great advice. Just overall, that's just great advice. So I'd like to pose one final question to the panelists before we get to our Q&A. What do you specifically want from headache organizations in terms of concrete resources? And LaQuinda, I'll start with you.
Honestly, I want more people that look like me. You know, that migraine retreat that I talked about last year was amazing. I met a lot of amazing people that I'm still friends with to this day. But there weren't a lot of people that looked like me. That was the first thing that I noticed. And honestly, I'm from the South. I mean, I was the only Black cheerleader in my school. And I'm used to, sadly to say, I'm actually used to being the only Black person in the world. But I want to see more people that look like me. I want to see more diversity when it comes to these, you know, the sitting on the committee, that's on the board, that's in these high positions, like, because that's when the change is going to come, when these people say, hey, you know what, we're lacking diversity. They can actually call it out. When you don't have anyone that's at the table that can understand, no one's going to call you out when you're slacking, when you're dropping the ball. So honestly, I want more people that look like me, more diversity.
Great. Isiah and Sheila, what would you like to see?
From me, I would like this, the institutional introspection to take a look at our board structure. How many African Americans do we have there? Look at our staffing structure. How many African Americans do we have actually on staff? And then to look at an assertive, coordinated outreach to the African American community, which Bob Dalton had recruited us to begin, but he transitioned from that organization. Those are the three things that come to mind right now. Sheila?
And for me, I would like for all of the headache organizations not to lump us into some cookie cutter category, because we're all different. Our headaches are different and we think different. We're from, even though we may be people of color, but we're from different regions, we're from different religions, and we're from different, probably socioeconomic backgrounds. So include more of us. You know, it's good to always, we always seem to just have that one. It's almost like only one can make it into anything that we do, into sports. We always have this one person we idolize over all of the rest of the athletes and over the rest of the entertainers. And with our organization, it seems like that's where we are. But I would like for everybody to be at that table, because we all have some valuable input. And there's an old African proverb, and I have used this before in some of our settings, is when spider webs unite, they can tie up a lion. So when we unite, we're more powerful than just one person at the table or two people at the table.
I love it, Sheila. That's great. And Nim.
Yeah, you know, I'm in a unique position because on the panel, I do lead one of the organizations as part of the space as the executive director. And so what I'm most grateful for is the opportunity to be able to create an actionable plan, something that goes beyond the introspection and conversation and says, we have to commit to this, we will commit to this, but not do it in a way where it comes off as performative, that we're trying to prove something. Rather, we're doing this for the right reason, and the right reason is to create that change and that groundswell of change. And also, I'd like to see all of our organizations, whether they're the professional organizations or the patient organizations, to do a call to action to somehow find a way to increase more opportunities for providers of color, Black, Indigenous, people of color, to say, I want to be a headache provider. Make the field attractive to people of color so that people like us on this panel have the opportunity to say, I feel represented and I feel that I can have a selection of a provider that I can go to that I'm comfortable with.
Absolutely. So we have received some questions prior to this evening's panel. One of the questions that we did receive that I would like to pose to the panel, and just please, answer as you feel comfortable. What can white patient or advocates like me do to help? I know there are the big systemic things, voting, advocacy campaigns, etc. But are there situations where we can act individually and move things in the right direction? What should we look for?
So I'll take a stab first and just say that creating a space, as an individual, having a space of acceptance, and if someone comes to you with their story or with their complaints of living with a particular disease, in this case, migraine, hear them and support them, but also connect them. There is nothing more important than connecting someone to resources, because you have no idea whether their circumstances allow them to be connected to those resources. So if you can be that link, be that link.
Yes, absolutely. And I think another good start is to look at your inner circle. Who are you surrounded by? Take a really good look at who your close friends are and how diverse are your friends, and try to make that more diverse and inclusive. Invite somebody for a coffee or to lunch. And I saw this really, really great YouTube video on bias, and the gentleman on it said to ask these two questions: what brings you joy and what breaks your heart? And those are two really, really great questions to really get to know somebody on the cellular level, on the human level. So that's another way just to get to know somebody and to really just make that human connection and to really start branching outside of your comfort zone of what you're used to.
And I totally agree with that. And also, I always like to say, you know, be a human first. You know, be a human first and listen. You know, because we don't mind sharing our stories, but if you have this energy of negativity and hostility, then you're going to get this, you know, this pullback, you know, from our community. So I would just say, you know, like create this open space that we can have this dialogue with you. And, you know, like I said, just be human first.
And I would agree. And I would say, listen with an open heart, an open mind, and an open willingness to do what's best for the patient. A lot of times advocates do what's best for the whole process. But sometimes advocate has to just kind of step back and say, how can I help you? Not so much as how can I make this process better, but just what can I do? Just opening up your heart to listen.
And one of the things that we learned from working with our children in school, in the school system, when we had challenges with the system, was to always approach the system from the standpoint, we're here because we're concerned about what's in the best interest of our child. Advocates, you know, from our perspective, they're there to see what's in the best interest of the patient. So that does require listening, that does require understanding, et cetera. So if they can take that approach, I think that would be helpful.
One other thing I'd like to add, if you are friends with people from the variety of communities represented by BIPOC communities, is referring them to organizations for leadership roles. If you see that there is a call for a board member or a committee member and from the variety of organizations in our space, please put that name up there for them to consider being a part of that leadership council, because organizations are sometimes so high level in who they're able to connect with that you never know that your suggestion and nomination from your community, and especially from Black and Indigenous communities, can really make all the difference to that organization and create the change that we want to see.
Yeah, absolutely. Such great information you guys are sharing, and resources and ideas. Just want to share some comments from some of our viewers. The Migraine Project shared such an important conversation. Thank you to everyone who has shared their insights and experiences. There's so much work to do to get healthcare people to check their prejudices at the door and truly listen to patients of color with invisible pain. And Erica Carrasco, as we know as Achy Smile, you know, one of our favorite bloggers, she said oddly she just realized that she looks for doctors of color rather because she's usually treated like a person and her story is heard and listened to. And she didn't think she realized that until just now, just from watching this. One more question. Are there any support spaces for people who are BIPOC with migraine? I personally don't know of any. This is something that I have a vested interest in wanting to curate and really make available to those communities of people. Because so often I think, you know, when those resources are, you know, sought after, there's just no representation there. And so when you don't see that, you know, you kind of just, you know, walk away from it. So it's important to have something in place for those communities so they feel safe enough and comfortable and we're not going to feel judged or feel like they have to deal with any biases or feel like they're going to have to over explain themselves or have to be defensive in any way. It's important to create those safe spaces. And outside of what we currently already have within the headache and migraine community and the organizations that already exist, I think it is important that there are those groups specific to BIPOC communities, because there's just a different sense of safety and well-being and community within those groups that needs to be preserved and respected. And everybody needs to embrace that is okay to have. And it's not a separation from what has already existed. That has been the history of this country. That has always been in place. But these other communities need to have somewhere to go that is, inclusive and to the BIPOC community. And they just have this sense of, I'm safe here. These people speak my language, they understand me, and I don't feel like I have to equate my pain to somebody's white experience, because honestly, that's what a lot of us feel like we have to do.
I'd also add to that, in partnership with the American Headache Society. So yes, Jamie, you're absolutely right. There isn't something in existence, and that's a much needed safe space that needs to develop and blossom and be nurtured. One of the opportunities and plans ahead for AMF with AHS is bringing a more diverse and culturally sensitive offering of resources to underserved populations that well and extend beyond the digital footprint. So that's not just offered on websites, that's not just offered on social media, and developing that program so we're able to meet people where they are, and B, not excluding anyone from the opportunity to be educated and empowered and get connected to the channels that they need to be connected to.
Absolutely, because tied to racial disparity are the socioeconomic disparities as well. And like you said, not everybody is connected or tuned in technologically. And so we have to meet people where they are, and you have to search those communities out and want to go into those communities and provide them with the resources that are attainable to them in forms that are easy for them to digest. And that takes a lot of work, but you have to be willing to do that. But also, it should not take other people of color to let white leadership of these organizations know that's what they should be doing. So the purpose of discussions like this tonight is to kind of put that in your ear, like these are things you should be organically starting to think of on your own. This has been a burden to us oftentimes to have to lead these conversations and get these things rolling, but that really isn't for us to do. But what we can do is just shed a light on what these issues are and help you understand these realities of so many people, and hopefully help you find a way where you can make some actionable way of making a change. Okay, I think we have 2 more questions before we tie up for the evening. How best should the headache providers and headache researchers best engage with the communities? Who would like to take a stab at that one?
There are multiple ways that that engagement can occur. One, like for instance, one concrete example at the clinician level would be seeking out, like for instance, the National Medical Association. That is the association for African American physicians. It began because historic segregation African American physicians were not allowed to be a part of the American Medical Association. So identifying groups that have an African American base and having dialogue with them, reaching out to them would be one approach. There are others, but I'll let Nim and LaQuinda and Sheila share some of those.
Yes, I was going to also add that one of the things for me, I do look for, African American doctors, and a lot of I had HMO insurance. So a lot of the medical groups, they didn't have, honestly, I didn't see any African American doctors in my medical group that I could go to. So opening up the floor to recruiting more African American physicians that, are in the community, that's, so that we could actually be able to see these physicians. Some of them are out of my network, out of my zip code. So like I said, just recruiting these physicians and bringing them closer to the community so that we have better access to them.
I agree completely. Nothing to add there.
Final question for the night. What do you suggest to say when you start to experience racial bias at the doctor's office or the urgent care or the emergency department?
Well, I'll just say when I was getting this type of treatment, like I said before, I basically, at that moment, I was in so much pain and shock, I really couldn't say much to that physician. But like I said, I did write a grievance. They have those cards where you can make comments. And believe it or not, they actually do read these. When I was a floor nurse, we would get tons of comments from patients that was on our unit, and they would read these. And it factored into our score so we can really see how we're doing. So write on those comments, and also take it higher. They have ethics committees in these hospitals and clinics, and they can listen to your story and really identify, hey, where's the disconnect? What's going on? So you really have to be vocal and just know that, hey, if no one else is going to do it, I have to advocate for myself. You know what I mean? I can't leave this office feeling like I'm hopeless, like there's no hope for me, like there's nothing that can be done. So just speak up for yourself, write all those comments, write a grievance, talk to the office manager. And like I said, there is the ethics committee that handle these types of things.
Yeah, I would add to that, to get really granular is in that moment, if you're feeling up for it and you're not distracted by your pain or whatever else is going on, pause and ask the provider, is there something about me or what I'm saying that you're not understanding? Because I don't feel like you're hearing me, and I don't understand why we can't come to a place of agreement around whatever you're trying to explain. Oftentimes, I think as a patient, we forget that we can challenge our providers, ask them questions, and even though we've been made to feel that we can't, we often should. And if that doesn't work, then just reframing it and say, I'm telling you A through Z, and I don't think you're understanding me. So is there someone else that we can bring into the conversation to hopefully get me to a place where I feel like I'm getting the care that I need? And then obviously with LaQuinda's suggestions is moving forward and upwards and onwards from there if that doesn't work.
For so long, we as African American women in particular always get branded as being angry, even though we're in pain and we're trying to express our feelings. That's the way, I don't know what it is. I think that's the way society has just begun to program themselves. It's not that we're angry. we're not going to be smiling when we're in pain, and we're not going to be laughing when we're in pain. When we're in pain, we want to be treated. But I have learned to use I statements and say, I feel this way, I am this way, this is happening to me, instead of saying anything else, you know, to get a physician's attention, to kind of take the focus away from the way they view me. It's like, this is the way I am feeling. This is the way I'm hurting. On a scale of 1 to 10, they normally ask you, I'm a 15, I'm a 20. And you try to diffuse by just using the I instead of saying, you're not helping me, or you're not doing this. Just always keep it about me.
And I guess the other thing is that each patient will understand how their healthcare provider operates. But if you're getting to the point to where they're actually not providing the care that you need, even after you challenge or question or make inquiry for clarification, then it's important to begin to think about how that transition is going to occur, to find another clinician who is patient-centered, because obviously you're going to need to continue to receive care.
All right. Those are excellent, excellent responses. And that was our final question for the night. I'd like to thank Nim, Isiah, Sheila, and LaQuinda for their time this evening and for sharing their stories with us on how racial disparity and implicit bias has impacted the care they have received in managing migraine and headache. Thank you to the U.S. Pain Foundation for bringing a very important topic to the forefront and allowing me to guide us through this conversation. And again, we thank our sponsors, Amgen and Novartis, for helping to make this event happen. And to everyone who has joined us this evening and asked questions, thank you. We all hope that this discussion has been enlightening to you and encourages you to become part of the solution. Thank you and have a very good night.